know it's been a long time since we had our last lecture on epigastric lung. Okay, but I've been busy with my residency at over here in Delhi, so I'm hoping that whatever breaks I get in between, I'm able to continue the lecture series. Okay, and hopefully we are able to cover as many topics as we can. Okay, so let's not waste time and just go ahead with the lecture. So last time we ended our clinic on the history part and the examination part of an epigastric lung. Okay, now once whenever you're done with this part and you come to the diagnosis, you usually are asked about the next question, that what will be the management of the patient. Okay, how will you manage the patient? Sorry. Now this management part mainly includes two things. One is your investigations, okay, and second is your treatment. Okay, so to know the investigation part, you should actually know what all investigations are available with us. Okay, and what investigation is required in which case. Okay, so I think for that you need to have a basic idea about these investigations. Okay, now all the investigations that we have are broadly classified into three main categories, or like we can discuss them under three headings, that is your blood investigations, your radiology, and your endoscopic procedures. Okay, now starting with blood investigations, your blood investigation, you should at least know the basic ones. One is your complete blood count, that includes your hemoglobin, your TLC. TLC is your total leukocyte count, or also your WBC count. Okay, second is your platelet count, and next is your hematocrit. Okay, now there are many other components, but I think at your level at least this much is what you should know. So coming to hemoglobin, hemoglobin you all know is usually seen, a low value is seen when there's blood loss, either in an acute setting or in a chronic setting. Okay, it can be a surgical blood loss, it can be traumatic blood loss, it can be because of some chronic disease or some malignancy. Okay, like we have seen a gastric malignancy that can lead to anemia over a period of time. Okay, next is your TLC, that is your WBC count, usually history of sepsis or infection. Okay, so the normal range is usually 4,000 to 11,000. Okay, anything less than that or more than that is history of infection and probably sepsis. Okay, is also seen in conditions of SIRS, what is known as systemic inflammatory response syndrome. Obviously, the term is dissolved now, but um, so any condition that leads to SIRS, that is your surgery, your trauma, burns, or any other stress, will lead to SIRS. Okay, and that can lead to leukocytosis or leukocytopenia. Okay. Next is your platelet count. Now, platelet count in surgical terms, most of the times, grossly is something that you need as a pre-op parameter. Okay, so uh, normal platelet count is more than 1.5 lakhs. Okay, anything less than that, for elective procedures, we usually investigate the patient. Okay, and we try to wait. Less than 75K, we need to transfuse platelets. Okay, they can be either single donor platelets, SDPs, or they can be random donor platelets. Okay, so this is one thing. Now hematocrit is your concentration of RBCs, concentration of cells, which is a marker of what is the fluid status. Okay, so the normal hematocrit level is three times of your hemoglobin value. So if your HB value is like 10, your normal hematocrit should be somewhere around 30. Now anything less than that is suggestive of dilute blood, or more than that is suggestive of concentrated blood. Hemoconcentration or hemodilution. These are better terms. Okay. So I think you can prefer that. Next, coming to your renal function test or kidney function test. Okay, both of them mean the same. The most important parameter that is seen in a renal function test is serum creatinine. Okay, serum creatinine is usually a marker of kidney function because it is excreted by the kidneys exclusively. Okay, and anytime there's any issue with the kidney, your creatinine levels, sorry, my bad. So anytime there's any issue with the kidneys, your creatinine level will start on rising. Coming to that, uh, you all should know what do we mean by AKI, also known as acute kidney injury. Okay, so the definition of AKI was given by KDO classification of 2012. Okay, which says, which has given like three criterias. Okay, now all the three criterias, it's better that you know all of them. One is your serum creatinine increases by zero point 0.3 milligram per dl in a period of around 48 hours. Okay. Next is the rise in serum creatinine uh, by 1.5 times of the previous value. Okay, within the period of 7 days. Okay. And third is urine volume. Now, many a times creatinine is not true. So, if your urine volume goes to less than 0.5 ml per kg for a period of 6 hours, that signifies AKI. Okay, so all these three criteria are important, and all these three criteria uh, suggest presence of AKI. Now, AKI in general can be broadly classified into three types. You must have read this in your medicine part, that it is pre-renal, renal, and post-renal. Now, this discussion, whatever we are having today, is we are limiting ourselves to the surgical part of all these investigations. Okay, there are obviously multiple medical causes, but right now we'll limit ourselves to the surgical causes. Okay. Now, what are pre-renal causes? Pre-renal causes is any time when there's volume loss. Okay. Now, volume loss can be because of blood loss. Okay, acute blood loss can be traumatic, surgical. Okay, there can be hypovolemia that is seen in your diarrhea, can be seen in vomiting, multiple episodes of vomiting, multiple episodes of diarrhea over a period of like in an acute phase. Okay, and in a patient who has a stoma, high stoma, usually an ileal stoma, where the stoma output is somewhere more than 500 to 600 ml, more than 500 600 ml, and there's constant fluid loss and electrolyte loss. Okay, so that again can lead to your pre-renal AKI. Next is your third space. Now, what do you exactly mean by third space? Whenever the body's fluid is not present in the intravascular space, it's known as third space. Okay. Now, this includes your ascites, your pleural effusion, and it includes your pericardial effusion. Really sorry for the notes, they are a bit crammed up, so I thought that maybe making up notes before will help me to like I don't forget anything. Okay, so I've just made this notes beforehand so that there's no issue with whatever points I'm about to tell. Okay, so there's a limitation of space, it might be a bit crowded up, but if there's any issue, please let me know on drop in the comment section. Okay. Yeah. So third space loss, it can be ascites, it can be pleural effusion, it can be pericardial effusion. Okay. Next comes your septic shock. Okay. Now, what do you mean by septic shock and why is it in pre-renal AKI? What happens in septic shock is all the toxins, they lead to peripheral vasodilation. Okay. So there's peripheral vasodilation. Now, what happens because of that is all the blood starts pooling in your peripheral circulation. Okay, and that leads to decreased flow to your vital organs. Okay, including your kidneys. Okay, so the GFR drops, and this leads to your pre-renal AKI. Okay, so that is why we prefer something known as vasopressin. What does vasopressin do? Vasopressin causes vasoconstriction in the peripheral arterioles, okay, which pushes the blood towards your systemic circulation, okay, and that thereby helps in decreasing the peripheral vasodilation that is seen. Okay. Next, yeah. So Next type of AKI is your renal AKI. Okay. Now this has multiple factors. It can include drug-induced injury. What are drugs? Many a times you are asked in exam. What are drugs that can lead to nephrotoxicity? Okay. So they can be NSAIDs. Okay. Your aminoglycosides, your diuretics, and chemotherapeutic agents. NSAIDs, except I think you all know this. Your paracetamol. Okay. Aminoglycosides, diuretics, and your chemotherapeutic agents. This CS stands for chemotherapeutic agent. Okay. Then as contrast, what is this contrast? These are your iodinated contrasts. All these contrasts, they are used for your CT scans. Okay. Now, why is this important? Okay. Whenever you need to investigate a patient for anything and you plan to do a CT, you can either go for a plain CT or you can go for a contrast enhanced CT. Now, what do you do in contrast enhanced CT? You inject an iodinated contrast intravenously, okay, and that will lead to better visualization of all the viscera, of all the soft tissue structures, okay, in general. Okay, so contrast obviously is required. Many times you cannot diagnose conditions without a contrast, okay, but it has its own drawbacks. It is nephrotoxic. Okay, so any patient who has a creatinine level of less than 1.2, you can go ahead for a contrast enhanced CT scan. But any patient who has a one creat of 1.2, you have to either lower down the creat or do a plain scan, okay, if that's possible. Okay, and along with that, if you have to do the scan in an emergency, you have to take consent, a high risk consent, where you have to explain the patient about the risk of nephrotoxicity. Okay, so that is important. So this was your renal AKI. Next is your rhabdomyolysis. This will be discussing at multiple places, but rhabdomyolysis can be seen in conditions like your burns, compartment syndrome. I hope you have a rough idea about what compartment syndrome is. Okay, we'll be discussing this in PVD chapter. Okay, there are multiple other reasons. Okay, then is your hemoglobinuria can be because of massive blood transfusion, usually done for trauma patients, or even your hemolytic reaction. Okay, hemoglobin, myoglobin, both of them are nephrotoxic. This is what you have to remember, the crux of it. Okay, then is your post-renal AKI. Now, post-renal AKI usually stands for your obstructive causes of AKI. Okay, now these obstruction can be either because of some compression. Okay, the compression can be in the form of mass, either a benign mass or a malignant mass. Okay, or it can be because of calculi. These are the two most common reasons that can lead to compression and resulting in post-renal AKI. Okay, now we come to the next investigation, that is your LFT. Okay, now liver function test is it's a white panel. It has multiple parameters to see. Okay, so we'll just divide them so that it goes easy. You all know it includes your total and direct, sorry, it includes your total and direct bilirubin. Okay, now total bilirubin is your direct plus indirect bilirubin. You all know we as surgeons are more concerned with direct bilirubin because they are usually seen in cases of obstructive jaundice. Okay, can be because of multiple reasons. Again, you know all of them. AST, ALT is seen whenever there's liver trauma or liver injury in any sort, can be a trauma. Trauma can be to the vascular structures or it can be directly to the parenchyma. Second, it can be drug induced. Okay, there are multiple drugs that can cause liver injury. One of the most peculiar example is your paracetamol, because paracetamol causes liver injury and not renal injury. Okay, then your alcoholic hepatitis. That is, yes, alcohol can lead to CLD, but alcohol can lead to alcoholic hepatitis as well. Okay. Next investigation is again a part of LFT is your synthetic function of the liver. Now this can include your albumin and your PTINR. Okay. Now albumin is the normal level of albumin in the body is 3 gram per dl. Okay. Anything below this is a marker of poor synthetic function plus a marker of poor nutrition. So any patient, if we are planning to take the patient for a major surgery, we have to see the albumin levels, and if the albumin levels are low, okay, we try to optimize the patient with proper nutrition plan with a dietitian, optimize the nutrition and try to bring the albumin to a normal level before we take the patient for the surgery. Okay, because albumin and protein level is essential for your wound healing and other factors. Okay. Next is your PTNR. PTNR is, as you all know, is a marker of coagulation status of the body. Okay. PTNR again is seen as a synthetic function of the liver. INR is mainly because of extrinsic pathway. Okay, mostly your 2, 7, 9, 10 factors. Please correct me if I'm wrong. This is what I remember. INR requires, or these factors require a vitamin that you all know, vitamin K. Okay, so any patient who has some component of liver injury or liver disease and his INR is deranged, we try to correct it with two things. One is vitamin K and second is fresh frozen plasma, which is a quick source of extrinsic factors. Okay. Next, now INR, one more thing is important. We usually consider a normal INR of less than 1.4. Okay. Now, whenever we are treating a patient of deep venous thrombosis or a patient who recently had a valve replacement, okay, these patients, they need to be in an anticoagulant state, okay, or we don't want them to be in the prothrombotic state, in an anticoagulant state, okay. So we try to maintain an INR of 1.5 to 2.5 in these patients, okay. And any patient who has a valve replacement, the INR that is maintained is 2.2 to 3, okay. This is maintained with the help of a drug which you all know as warfarin. Okay, so whenever a patient is started on warfarin, we regularly check the levels of INR and we try to achieve a therapeutic range of something like this. Okay, anytime the range goes below or more than that, we accordingly change the dose of warfarin. Okay, because that is what will treat the deep venous thrombosis or will help in maintaining the valve patency in a case of valve replacement. Okay. Again, warfarin. So warfarin antidote is vitamin K. I think that's like pretty straightforward. Okay. Coming to the next parameter, that is your ALP. ALP stands for alkaline phosphatase. Okay. And GGT stands for gamma glutamyl transferase. Both of them are your markers of cholestasis. Now, what is the difference between them? ALP, alkaline phosphatase, is also seen in multiple other places, like your bone cells, okay, osteoblastic cells, and in cells of the hematopoietic system. Okay, so anytime there's rapid multiplication of any of these cells or there's osteolysis, okay, in these conditions also alkaline phosphatase is raised, because alkaline phosphatase is not specific for liver. Second thing is your gamma glutamyl transferase. Now, this this enzyme is more liver specific and can be used as a marker of your GGT. Okay, GGT is also raised in conditions of alcoholic hepatitis or alcoholic CLD. That is another thing you should know. Okay. Now coming to your next investigation, that is your serum electrolytes. Serum electrolytes can be your the most important ones are sodium, potassium, and calcium. Okay. Now hyponatremia is more significant in surgical cases because it is mainly seen again in conditions of hypovolemia. Can be seen because of excess IV fluid being given for any reason. Okay. Can be seen in GI losses. Now GI losses can again be in the form of diarrhea, can be in the form of vomiting or a high stoma output. Again, whatever we have seen in pre-renal leakage. Okay. Increased sodium hypernatremia is that's an interesting thing, but the surgical causes that are usually seen is burns. Okay, because there's dehydration. Free water loss is more because the skin cover is lost in these cases. Okay. The second most usual cause is an open abdomen, usually a leprostoma. What is a leprostoma? So whenever a patient has a gross contamination, okay, or you plan to take up the patient for a second surgery, and that you know already in the first surgery you plan to keep the abdomen open, okay, and you cover it with the bag, usually known as a Bagota bag. Okay, this is known as a Bagota bag or a leprostoma. Okay, in these cases, loss of free water again is more, and that can lead to your hypernatremia. Okay. Next is your potassium. Potassium is again an important thing in surgical cases. GI losses are important causes. Okay. One most important key thing that we have discussed and is important is your gastric outlet obstruction. Okay. We're going to have a detailed discussion on this part when we discuss the management part of your epigastric lump again after this module. Okay. Next, coming to your diuretics, you all know your loop diuretics and your thiazides lead to excretion of potassium significantly. Okay, so they are responsible for hypokalemia. Refeeding syndrome. I would like to discuss refeeding syndrome so that just in case we miss it anywhere. Whenever patient has been in a state of chronic malnutrition for a very long phase, okay, what happens is his cells are depleted, okay, and depleted of glucose or depleted of energy. Okay, and whenever you give excess glucose, okay, all the cells in the body, they try to take up as much glucose as they can. Okay, and this results, and to take up the glucose, your body needs insulin. Okay, so insulin is secreted in large numbers whenever this glucose is given. Okay, now what happens because of insulin? One most important characteristic of insulin is it causes movement of extracellular potassium to intracellular, from extracellular side to an intracellular side, and that leads ultimately to your hypokalemia. Okay, your cell becomes hungry and it takes up all the nutrients including your potassium is an easy way to remember. Okay, so whenever you ask about refeeding syndrome, all the ions, okay, your calcium, magnesium, all of them start moving inside the cell. Okay, so there's a generalized hypo seen in your refeeding syndrome. Hypophosphatemia is a very significant feature of refeeding syndrome. Many a times you ask this as a question. Okay, refeeding syndrome, hypophosphatemia, hypokalemia, calcemia. Okay, so that is important. Now, next investigation. I hope we have not missed anything. Okay, yeah, yeah. There is grossly. Yeah, one more thing I want you all to remember is hypokalemia. So potassium. Why did I say that potassium is important for surgeons? In whenever a patient undergoes surgery, a massive surgery, there is a lot of tissue injury. Okay, the cell breaks down and there's release of large amounts of potassium in the circulation in the extracellular space, and that is ultimately taken up in the circulation. Now, what happens because of this is in the initial early pre-op days, usually 1 to 2 days, the potassium levels are high. That is, patient has hyperkalemia. Okay. After this phase, body starts utilizing. Sorry. Your body starts utilizing large numbers. Body needs potassium for growth. Okay, and your it is electron transport chain. Okay, so this potassium this ultimately leads to hypokalemia in the body. Okay, so this is one important thing that usually in the early post-op phase there's hyperkalemia which eventually goes to hypokalemia. Okay, second thing that you need to know is potassium is again important because uh, whenever a patient undergoes a bowel surgery, okay, the bowel goes in something known as paralytic ileus because of the action of your anesthetic agents, okay, under the action of your general anesthesia. Okay. Now, what happens in this case is there are multiple parameters which can lead to delayed recovery of your bowel loops uh, into peristalsis phase. Okay, and one of the most important parameter that is seen and that is always checked in first hand is your hypokalemia. Okay, so we always try to replenish potassium in the post-op phase. Okay, along with your magnesium. So both these parameters are important for your paralytic ileus in the post-op phase. Okay, so this is just one point you need to know. Then coming to your tumor markers, the tumor markers are something that give you an idea about the possibility of disease. They are not completely diagnostic, okay, but apart from that, they also give you an idea about the prognosis or whether there is a possibility of metastasis or extra vessel spread of the disease. Okay, like PIVKA, CA, CA19s. Their early stages, small levels can tell you about a malignancy, but high stages are very significant or suggest you of a metastatic disease. Okay, so this is what you can say that they are prognostic. Okay, all these parameters. AFP, PIVKA, they are seen in your liver tumors, liver malignancies in general. CA is seen in colonic malignancies. CA19-9 is seen your biliary and pancreatic malignancies. Okay, so there is just this much in body order. Now there are multiple other blood investigations which are done in these scenarios, but these are grossly the important ones that you all need to know. Okay. Whenever we come to the respective part, we'll discuss the other investigations that are important. Okay. Now coming to your radiology, what are the radiological investigations that we do? You all have an idea, gross idea about this. Okay. The first most common one is your X-ray. We as surgeons, the most common X-ray that we do is a chest X-ray and an abdominal X-ray. What are seen in a chest X-ray when we have a discussion about your X-ray radiology and all we'll discuss. But X-ray gives you an idea about, chest X-ray gives you an idea about the most important thing is the perforation. Okay, whenever there's gas in the diaphragm, it suggests that there is intestinal perforation or hollow viscous perforation. Okay. Next is it can give you an idea about effusion in trauma settings. It can tell you about hemothorax, pneumothorax, okay, and many other scenarios. Okay, we also see it post-op to see fluid status. If a patient has a lot of pulmonary edema, there will be changes seen on the X-ray. That is important. If you have over-resuscitated the patient and given him excess of fluid, there will be changes on the X-ray. Okay. Coming to your abdominal X-ray, now abdominal X-ray can give you an idea about many conditions, like usually the basic ones. So bowel conditions are seen a lot. It gives you an idea about obstruction. Okay, Your abdominal X-ray KUBs can give you an idea about your obstructive hydronephrosis, hydroureter. Okay, so there are multiple settings when we do the X-rays. Whenever we go to the respective topic, we'll discuss them. Okay, barium studies. Now, many a times, many people get confused with what are the types of barium studies. Okay, so I want you all to understand this very clearly today. Barium swallow is something that is like done instantaneously. You ask the patient to swallow and you take chest cuts. Okay, so barium swallow is for your esophagus. Your barium meal is for your stomach. What is that? Okay, and usually the duodenum. Barium follow through is for your small intestine, and barium enema is for your colon. Okay, obviously it is given correctly. Okay, so this is the gross idea. You should know when do you say what investigation is done in which pathology, okay, or which organ you are dealing with. Coming to your USG, now USG you all know what it is. It's ultrasonic waves being used to diagnose conditions. Okay, now where all is USG good and where is CT better? Okay, so this is something many of you confuse. Now USG is very good for your hepatopancreaticobiliary conditions. It's good to visualize lesions in the liver. Obviously CT and MRI are better, okay, but USG can give you a basic idea. USG is much better for your gallbladder pathologies as compared to your CT or MR at many a times. Okay, cholestasis and all can be better diagnosed with USG at times. Okay, so only USG you can rely on for these conditions, for the gallbladder conditions. Okay, obviously for the extent and state, if it's a malignant condition, you have to do a CT. Then for your vascular conditions, vascular can be your Dopplers. Okay, any place you have to do a Doppler. It's a dynamic study. We do a USG. Okay, your lower limb Dopplers, your upper limb Dopplers. Okay, so any Doppler we do, it's a USG. Okay, aside is any fluid in the body anywhere, USG is excellent. Okay, and you all know about FAST. FAST stands for focused assessment by sonography in trauma. Okay, you all know the components. Okay, what all we see, what all quadrants have seen. If not, we'll discuss it in the respective chapter. Okay, so this is what you all should know. Coming to CT, CT is usually good in identifying lesions that are small and that are not picked up on the USG. Okay, it can give you an idea about margin of the lesions. Okay, and can help in preoperative planning. Usually, we need a CT for preoperative planning of multiple tumors or multiple surgeries. Okay. It's excellent in trauma settings, gives you an idea about multiple organs that can be involved, can give you an idea about polytrauma. Okay, CT is excellent for you. At many centers, there's something known as whole body CT, which is done to just rule out every other pathology that can be there in a trauma setting, because there can be a polytrauma, a missed polytrauma in any patient. Okay. We have already discussed about the importance of creatinine in doing a CT or a contrast enhanced CT. Okay, there's something more that is done in a CT is an oral contrast. Okay, again the same contrast that is given IV is given orally. Okay, and it visualizes your hollow viscous. So suppose if it's done for the stomach, for a lesion in the stomach. Okay, the OC will fill up the part that is not occupying the lumen. Okay, and it will give you a filling defect. Okay, the word that is normally seen is a filling defect, and if it's a malignancy, there's a possibility there will be irregular contour. Okay, that will be seen. So that is where an oral contrast is helpful. Okay, and all these conditions where we have to see the bowel, or even in an obstruction, we give oral contrast to see what the level of obstruction is. Okay, so wherever the contrast doesn't pass ahead, that means that is an obstruction, and proximal to it there will be dilated bowel loops. Suppose there is a stricture over here, Okay, these loops will be dilated. Okay, now there are multiple parameters, multiple characteristics to what level it should be dilated, because there's normal peristalsis going on and anyone can confuse normal bowel dilatation, normal peristalsis with bowel dilatation. Okay, so that is important. Next is your MR. MR is more of a soft tissue scan. Okay, it's good for your neurological imaging. MR, we as surgeons most commonly concerned are with MRCP. Okay, uh, and obviously tumors in the rectum, we prefer MRI. Okay, so MRCP is we give a contrast which is excreted in the biliary system. Okay, and it opacifies is the word that is used. Opacifies the entire biliary system, give you an idea, excellent idea about the biliary tree and any obstruction, any growth, okay, any injury that has taken place at the time of any surgery, okay, is well seen on an MRCP. Okay, so that is important. Many a times you are asked where we do MRCP. Biliary pathologies, MRCP is great. Okay, even for the pancreas. Okay, this tract is also easy. So that is what you should know. Okay, MRI is also good for your peripheral lesions, any tumors in the periphery like sarcomas. Okay, the most common tumors. One of the most common lesions in the periphery are your sarcomas. Can be from multiple origins. Sarcomas can be from the lipid. Sarcomas can be from the muscle or from the bone. There is no hard and fast rule. Okay. So all these sarcomas, you have to see the margins, you have to see the extent. We do an MR. Okay. Next investigation that we all know about is the PET scan. Now, PET scan is a whole body investigation. Your entire body is screened. Okay, we give a something known as 18F fluorodeoxyglucose. Okay, also known as FDG, fluorodeoxyglucose, where this glucose goes in all the cells that are using uh, glucose. Okay, but this glucose does not undergo further metabolism. Okay, now cancer cells have usually have a high rate of glycolysis. Okay, and that is the reason why FDG is seen accumulated in your malignant cells. Okay, so anywhere there's high FDG uptake, there's a possibility that there's a tumor or a malignant lesion, or it can even be seen in high metabolic regions like your inflammatory lesions. Okay, so false negative can be seen in a PET scan whenever there is an infective or inflammatory foci. Okay, this is one thing you should remember for your entire life about PET scan. Okay, so PET scan will not always tell malignancy, it can also tell you about an inflammatory region. There are multiple parameters to know whether it is malignancy or not, but not of your level. Okay, but this is just a gross idea of what you should know. Okay, now coming to your next investigation, that is your endoscopy. Endoscopy is mainly the multiple obviously now there are multiple procedures being done, multiple therapeutic options that we have with endoscopy, but the important ones we'll discuss here. So the first one is an upper GI scopy. Upper GI scopy, ogiriscopy, or esophagogastroduodenoscopy. The entire name, I'll just write it down for you to understand. Okay, so I want you to understand one important thing. Whenever we are dealing with a luminal structure, starting from your mouth to your esophagus, to your stomach, your entire intestine, be it small intestine, colon, okay, or rectum, or even the anal canal. We have to get a biopsy to confirm the diagnosis. Okay, we cannot just rely on imaging for we cannot just rely on imaging for these lesions. Okay, now the that's the reason why all these investigations have been developed. Okay, so any lesion starting from the esophagus or even the oral part till the duodenum second part. Okay, any lesion that's there, we can do an upper GScopy. What are the indications of upper GScopy? There's bleeding, hematemesis. Okay, there's dysphagia, usually seen in esophageal lesion, can be benign, can be malignant. There can be ulcers, you all know, can be benign, malignant again, can be malignancy, and if it's malignancy, you have to do something that is biopsy. Okay. Again, if there's bleeding, you can do therapeutic procedures to control the bleeding. There are multiple things known as banding, EVL. Okay, I want you all to find out what EVL is. Okay, that's like a homework and read about it. What EVL is. Okay, and the other option is sclerotherapy. Okay, only if you read it, you will remember it. What is EVL and what is sclerotherapy? I hope most of you must be knowing, but if you don't, just go home or close the video and see what EVL is. Okay, yeah. So coming to your next investigation, that is your colonoscopy. Colonoscopy is done for your colonic part. Okay, we start from the rectum, we go to the sigmoid, then the descending flexure, the transverse colon, the hepatic flexure. Okay, then comes the cecum, and from the cecum you intubate the scope into the IC junction, into the terminal ileum, and we come back from the terminal ileum. Okay, this is the entire area that is seen in a colonoscopy. Okay, so again the indications are somewhat plus minus the same. Bleeding can be one important investigation is inflammatory bowel disease that is seen in a colonoscopy. Okay, and any lesions that you all know. Okay, now colonoscopy, one more thing that you have to know, for an OGD scopy or upper GI scopy, before the procedure we have to keep the patient nil per oral. Okay, for usually from the midnight before the procedure is done. Okay, so that there's no risk of aspiration whenever we do the procedure, because whenever we put a scope, okay, the entire tract is open and there's a high risk of aspiration. Okay, so we usually keep the patient NPO, plus the visualization becomes bad. That is one more reason. Second thing, now this is for upper GI scopy. For a colonoscopy, now obviously if you're planning to give an anesthesia, we keep the patient NPO, but along with that we do something else that is known as bowel prep, bowel preparation. Okay, for this there are multiple agents. The most common one that is used is polyethylene glycol, in short also known as PEG. Okay, you must have seen when you go to endoscopy, you see any patient who is undergoing colonoscopy will they'll ask question to the patient. Okay, कि आपने 2 bottle पानी पिया था क्या? Okay, that pani has this powder, okay, or a liquid, can be anything, and this causes constant diarrhea, or it has a catalytic action that will empty entire bowel loop or the entire colon. Okay, so that the visualization becomes better and risk of injury goes down. Okay, so any patient who's planned for a colonoscopy, we have to give bowel prep. Okay, and along with bowel prep, obviously one more thing, as I've said, with bowel prep there will be a lot of diarrhea. If there's diarrhea, you have to give the patient IV fluids and supportive treatment. Okay, like ORS, oral rehydration solution. Many times if the patient is admitted, you can even give IV fluids. Okay, The next investigation that I want you all to know is your endoscopic ultrasound. Okay. Now, endoscopic ultrasound is nothing but an upper GI scope, an OGD scope attached with an ultrasound probe. Now, what it does is, because many of you don't know what we exactly do in an EUS. Okay. So this is the mouth part. Okay. This is your esophagus. This is your stomach. Suppose there is a lesion that is there in the esophagus. Okay. Now this is the mucosa. Consider the red line as the mucosa. Okay. And there are multiple layers, as we all know. There is the mucosa, submucosa, okay, muscularis propria, and I won't say the fourth layer. You know why? Okay. Now, why will I not say the fourth layer? Which part of the body, which, or again one more, which part of the like GI structure lacks your serosa, and which part of the body lacks submucosa? This is a question for you. Okay. Do reply on the group or just read it for yourself. Okay. Yeah. So what we do in endoscopic ultrasound is we go ahead. Okay. There's a probe attached over here that will scan this area and give you an ultrasound image of this area. Okay. So that you know that which layer of the esophagus is the tumor exactly involving. Okay. So is it just the mucosa, or is it the submucosa, or is it the muscularis propria? Okay. Or the next layer? Okay. So US gives you an idea about the depth of invasion, also known as local staging. Also labeled as your T staging. Okay. So this is one thing. Secondly, now if this esophageal cancer along with the lesion has some nodes, again your ultrasound can see beyond the wall of the esophagus, so it will give you an idea about nodes being present in this area, mediastinal nodes. Okay. One more advantage of this probe is that it can do a biopsy, just like upper GI scopy. There's something with which you can do a biopsy. Okay. But the advantage in this case is it can go beyond the wall of the esophagus and do a biopsy. Okay. And you, because you have the ultrasound probe in hand over there, you won't be enjoying other structures. This is the advantage of EUS, endoscopic ultrasound. Okay. I hope all of you are clear with what an endoscopic ultrasound can do. Okay. So this is grossly the entire discussion about investigations that we usually do in surgical part. Okay. Now there are multiple other investigations, but as we discuss the respective topic, we will touch that topic. Okay. We'll touch the investigation and then go ahead. Okay. So let's just end the discussion over here. Any doubts, any questions, again you can put it on the comment section or in the group. Thank you.